Okay. Good morning, everyone. I will call this meeting to order. I will confirm that all members are present with the exception of Warden Hicks at this time. The first order of business will be the election of the chair and vice chair for 2021. So I will open the floor now for nominations for chair for 2021. Councillor Robinson.
Thank you and good morning to everyone. I would like to nominate Scott Mackey for chair of this committee. Thank you.
Okay. Do I have a seconder? Councillor Woodbury. Thank you. Are there any further nominations for chair? I'll ask again, any further nominations for chair? Can I have a motion to close nominations, please? Councillor Burley, Councillor Klumpus, thank you. Councillor Mackey, are you willing to accept the chair for the Committee of Management?
Thank you, Madam Clerk. Yes, I will accept it.
Thank you very much. I will now open the floor up for nominations for vice chair for the Committee of Management for 2021. Councillor Woodbury.
I'd nominate Councillor Burley.
Okay, thank you. Do I have a seconder? Councillor O'Leary, thank you. Any further nominations for vice chair? Councillor Mackey.
I would nominate Christine Robinson.
Okay. Thank you. Do I have a seconder? Councillor Klumpus. Thank you. Any further nominations for vice chair? Can I have a motion to close nominations, please? Councillor Klumpus, Councillor Woodbury, thank you. Welcome, Warden Hicks. Councillor Burley, do you wish to stand for vice chair?
At this time, I think I'll withdraw and welcome Christine.
Thank you.
Thank you. Christine, you're willing to stand for chair, vice chair?
Yes, thank you to my nominator and seconder, and thank you very much, Councillor Burley. You're very gracious.
Okay, thank you. So we have Chair Mackey and Vice Chair Robinson. Chair Mackey, I will pass the meeting over to you now.
Well, thank you very much, Heather, and thanks to my nominators and thanks for the support of the committee members. I know we're all here because we share a common goal and common interest in looking after and providing the best service and outcomes to our most vulnerable seniors. So I appreciate the opportunity and I look forward to working with all of you. Just like to extend a sincere thanks to our senior management team and all the staff at long-term care facilities. The protocols that have been developed have certainly been effective, and we've been getting through this pandemic as well as could be, well, better than could be expected. So our hats, our best wishes go out to the long-term care staff and all of our residents. And we do have some good news with the vaccine arriving later this month. And as we're aware, it's going to be earmarked for our long-term care facilities and staff. So that certainly is tremendous news and will certainly help in our fight against this pandemic. So with that being said, we'll call the meeting to order, and just to remind the members of their obligation to declare pecuniary interest. Seeing nothing, if anything should arise, you may declare at that time. We have the operational report, long LTCR-CM01-21, October 15th to December 14th. Can I have a mover to get that on the floor, please? Moved by Councillor Burley and seconded by Councillor Robinson. Jennifer, are you going to start this report?
Sure, thank you, Mr. Chair. I'll just start by letting the group know how we're going to present this report. So this report covers the months of October 15th to December 14th. Renata is going to give an update on the quality piece, and then each executive director is going to give a summary of a highlighted area, and then we're available for any questions.
Okay, thank you, Jennifer. We'll turn it over to Renata.
Thank you. The High released its Q2, which is July to September indicators at the beginning of December. And as you can see, we have several areas that are above the provincial average. And in speaking with the care communities, this is starting to be reflective of COVID and the pandemic and the isolation of the residents, limited physiotherapy, and as well as resident acuity in general is increasing. The teams are continuing to work on data quality and ensuring that they're capturing everything accurately. The teams are also working on their annual program reviews, which is a review of the skin and wound care, pain management, falls prevention, etc. That information will be used by the end of this first quarter to develop a quality improvement plan for 2021, both corporately and for each individual care community. Are there any questions?
Any question from the members? Seeing nothing. Thank you, Renata.
Mr. Chair,
Sorry, go ahead, Christine.
And I do apologize, Mr. Chair and committee, and my question arrived in my head a little late, but I'm just wondering, Renata, thank you very much for the quality control plan that will be coming forward. I'm just wondering if you could provide a snapshot in terms of how the training would unfold for that Q plan. Thank you.
Our staff currently, we've been creating quality improvement plans annually all along. And so myself and the senior leadership team will review and analyze the data that's brought forward to us, and together we'll develop the quality improvement plan. Additional training will be through support from myself to the teams to develop the plan.
Thank you.
Okay, we will now take some highlights from the individual homes, and who would like to go first? Okay, yes, I guess I'll choose. Shannon, you've got the floor.
Okay, I'll go first, thanks. So during this report, we had a ministry inspection visit in November that was a follow-up to an RN staffing compliance order and a critical incident that resulted when a resident fell and was injured in the home. We received 2 compliance orders and 1 voluntary plan of corrections from this inspection. The 1 compliance order was that the care plan was not effective and different approaches were not considered. Corrective action for this has been that the plan of care has been reviewed, changed, and staff have been re-educated to ensure that the care plans are appropriate for each resident. The other compliance order was that the head injury protocol was not followed and assessments completed. Staff have been re-educated on this policy and audits completed to ensure compliance. The voluntary plan of correction was around the skin assessment, where the staff failed to conduct an initial skin assessment of the wound. Staff have been educated and audits completed to ensure weekly assessments are completed and conducted. The other part of our review was the RN staffing compliance order, and it was found to be in compliance and has been put back into compliance during this visit. Does anybody have any questions in regards?
Any questions from the members?
Yeah.
All right, thank you, Shannon. Karen, we'll go down to Rockwood.
Thank you, Mr. Chair. If everybody could turn to page 12 of the report, I'm going to talk briefly about influenza immunization. Influenza has kind of taken a back seat this year to COVID, but nevertheless, we still have some procedures in place for that and did offer the annual influenza vaccinations. They are also ongoing in all 3 homes. Staff could still receive one of these, or if we are hiring new staff, we make sure that it is offered to them. The results from the homes at the time of the report are listed there for your reference. And we are required to provide these stats to public health no later than this Friday, January 15th. So all homes, if they haven't already done so, will be providing those statistics to public health. The other thing I want to talk about briefly is a great news story, and maybe some of you seen it on the news because it went down as far as CTV and Kitchener. But on page 14, I outline a little event where we helped a resident complete an item out of her bucket list, and that being instructions in ballroom dancing. So there is a video, I believe, available on the Grey County website if you haven't seen this. But like I said, CTV picked it up and it was on the Saturday evening Kitchener News. So that was pretty amazing. The resident herself was pretty proud and pleased, and it was a big joke around the home here that it had went viral. And then they made a joke on that as well, as long as we don't get the virus. And so it was a pretty cool situation, and where we're all great to be a part of it. It was a very emotional day.
Thank you, Karen. That certainly is a good news story. It's nice to see that we were able to accommodate some bucket list. Any questions from the members? Seeing nothing, we'll turn it over to Stacy. Congratulations, Stacy, on your permanent appointment to the executive directorship.
I thank you very much for that, Mr. Chair. The Ministry of Health Long-Term Care visited Lee Manor several times during this reporting period also, so I thought I would focus on this specific area to report to the review, with the committee. They were in the home on 3 different occasions, and the first was back in September, and we had 1 to 2 inspectors here on site for a stretch of 8 days, where they conducted a complaint inspection along with a critical incident inspection. And the outcome of the inspections did result in some non-compliances. As a result of the complaint inspection, we were issued 3 voluntary plans of correction. One was related to resident allegation of improper care, which was documented by staff, but appropriate follow-up wasn't conducted into the incident immediately as per our policy. So to address this, we have had re-education with the staff regarding process and their responsibilities for reporting allegations. And we've also been monitoring the 24-hour report on a daily basis to ensure that there's adherence to the policy. There was also a voluntary plan of correction regarding skin and wound care. And as per our policy, an initial skin and wound assessment should be initiated for all areas of altered skin integrity, including bruising of any kind. This assessment did not occur, and in not doing so, there was no regular monitoring to ensure the bruises were healing and there was no underlying injury. So as part of our voluntary corrective plan of action, the nursing staff have been re-educated regarding skin and wound protocols. And again, we've been auditing documentation to ensure compliance with the policy. And the last was related to medication administration, whereby the registered staff did not follow our protocols. And again, this is recognized and actions have been taken to ensure compliance, including current policy review and routine monitoring of registered staff documentation. Regarding the critical incident inspection, we were issued a compliance order. And in this case, a resident sustained a fall resulting in a medical injury where an incorrect safety device was applied to transfer equipment, and the level of assistance as outlined in the care plan wasn't followed. So the compliance order outlined 4 specific items that we needed to address by November 24th. And although I didn't have the report available at the time of submitting this report, they have since returned and have confirmed that we are now in compliance with the order. So that's good news. Inspectors were back in the building in early November for a period of 2 days, and they completed a critical incident inspection at that time related to resident neglect. The inspector interviewed staff as part of that process. They reviewed clinical records and also observed staff interactions with residents, and there were no compliance orders issued at that time. They returned for a 3rd visit in December, where they spent several days on site to complete another critical follow up to that compliance order that was issued in October. So Although I have the report now, it wasn't available at the time of this report, so I'll have an opportunity to discuss that at our next meeting. I would like to say that, although inspectors share opportunities for improvements when they're here, they also recognize some really positive observations when they are on site. And certainly some of the things that they've noticed us on their exit visits include things like they're very grateful to the staff for the work that we're doing under the pandemic. And they also commented on our staff and resident interactions and how impressed they were and our willingness to be, willing and cooperative participants through the inspection process. And certainly they recognize our environment and say, always have wonderful things to say about how bright and cheerful the environment seems under the circumstances and how clean and well kept it is. So it's nice to hear that not only are they here to help us, support us with making improvements, but noting some positive things why they're here as well. And that's my report. Is there any questions?
Thank you, Stacey. Any questions from the members? Councillor O'Leary?
Thank you, Mr. Chair. I have questions on the compliance orders and inspections findings. Is now an appropriate time? I should address these to Jennifer. I've highlighted a lot of things here. The licensee has failed to ensure falls and prevention, corrective action, retraining of staff. Written notification was issued, failure to investigate, respond, and act immediately, correction, re-education of staff. There's a lot of them. And to be honest, I'm not getting a real warm and fuzzy feeling here that, I don't know if our staff is overworked. I don't know if we have a manager on staff overseeing what they're doing on their actions. I just have a hard time understanding that these staff members have to be retrained over and over and over again because of mistakes made on something that, even looking after an open wound. I mean, that's what they're trained for. They don't just forget. And I just think there has to be tough questions asked about this because it just doesn't seem right to me. Now, that being said, all of you are probably tired of hearing about my own mother because I always tell the stories, but when she was at Lee Manor, she fell 4 or 5 times. She broke a hip, she hurt her tailbone, she smashed her head, and every single time she fell, she was just flat out being stubborn and there wasn't anyone able to help her because she was just walking. So I have to ask the question, is staff taking the heat for some of these patients that are just, there just has to be something missing. And I guess my final question is there something that we can do to be proactive? Is there training that we can do? Do we not have enough staff? What is the real problem behind all of this?
Okay, thank you, Brian. Jennifer, do you want to field, there's 2 or 3 questions in there. Do you want to attempt to answer those?
Sure, thank you. Thanks, Mr. Chair. And Councillor O'Leary, you're right, there's a lot. There's a lot bundled up in these reports. And I think your summary hits on, and your questions hit on a number of areas and opportunities. So so there's a significant amount of regulations, which is good, and requirements to report on any critical incident. And the list of critical incidents is very lengthy, which is also good. So the ministry comes in, so we report when things happen, like falls or a skin tear or an allegation of neglect. And we do an investigation and we make changes and improvements, and the ministry comes in and they do their follow-up on those reports and inspections. And if we were to, and we can do this, we will be doing some more in-depth discussion in closed session on specifics. And so when we dig into the specifics of each of the situations that result in opportunities to do better, there is lots of nuances and key factors that aren't just can't be just explained with a broad brush, if that helps. So if we were to dig into some of each of these individually, there are definitely areas that we can make improvement. And there are also one-off situations or resident-specific or staff-specific or the circumstances that if we tried to recreate those circumstances again, we'd never be able to do it quite that way in 100 years. It's just with the number of things that are going on in that particular moment. So what can we do and what are some of the opportunities? In the COVID update, I'm giving an update around the successful recruitment of a clinical specialist. And so that clinical specialist is really going to help pull together this information and help us make some very pointed plans to look at our systems. And the other piece that I look at, and I have the reports pulled up, and if we look at one of the reports for the orders, at the bottom of an order, the ministry looks at 3 different areas. They look at severity, scope, and compliance history. And so at Grey Gables, both of the orders, the severity is low. The risk of harm to the individual is minimal. But then when you take into consideration that they found that situation in more than 2 residents. And if they look back over 2 years or 3 years, this has been a systemic thing that we've been working on and have not quite got it quite right. So they look at all 3 of those areas. With the situation at Lee Manor, it was a one case situation where the risk was high to the resident because they were injured, but the scope was very small. It happened to 1 person, and the compliance history, there was no history of any similar thing happening in the past. So there are lots of factors that the ministry takes into consideration when they determine compliance or non-compliance. So I think our opportunity is to use that information and to make changes to our systems so that the staff have the tools they need to do what needs to be done every day. The budget that we're presenting that this committee has reviewed and that we're talking about at the next budget meeting has investments in staffing hours that will help support the day-to-day, moment-to-moment care of the residents. And then the clinical specialist will help support the leadership teams, the clinical leaders in helping us stay focused on fixing those and working and educating on those particular areas that make the most difference to the residents. Does that help a little bit, Councillor O'Leary? Any other?
That was good, thank you. And Mr. Chair, if I could, I just have a comment too. The other thing that kind of stuck out too is, I don't know about these inspectors or how it works, but you know, at Lee Manor, inspectors were on site September 29th, 30th, October 1st, 2nd, 5th, 6th, 7th, and 8th. Like they almost overdo it sometimes. It must be, I guess that's a tough question. You can't really say one way or another, but it seems like it's pretty tough. Like if they smell something, like they're just kind of all over you.
Through you, Mr.
Jennifer, can you maybe just talk about the overall compliance process and how involved it is?
Sure. Yeah, through you, Mr. Chair. And my internet was a little bit crackly, but I think I got the question about the number of visits. So we are actually doing some further investigation into better understanding the amount of visits that we're getting in Grey County. So anecdotally, it seems like some homes aren't having any visits, and then others they seem to be camped out. So one of the factors that we do know the ministry takes into consideration with level of risk is leadership. And if there's been changes in the director of care, the associate director of care, the executive director within a period of time, that raises that home on the list of risk. And so both Grey Gables and Lee Manor have had leadership changes in the past 18 months. And so we wonder if that may be playing a role in the number of inspectors on site. The other thing is that we believe in transparency and following the rules. And so if an incident happens and it meets the criteria of needing to be reported, we report it. And so we have, and you'll see in our closed report next month, that we have a number of critical incidents reported. And so the ministry follows up on those. And when an inspector is on site for a couple of days, digging into in kind of a vacuum, then there's more opportunity to be looking at all sorts of things. And sometimes it's dotted I's and crossed T's, and sometimes it's more significant, and we absolutely need to be making improvements and having that brought to our attention. So they do seem to be on site a lot, but if we look back over the last 2 or 3 years, anecdotally, it feels like they've been at least 1 or 2 or 3 of our homes a couple of times a year. So maybe this is it for a little while, because I do think it's worth noting that during all of that time, Lee Manor had 2 false positive, full outbreak protocols, scares where this team is doing full outbreak protocol, droplet contact precaution, tray service. So it does also raise the level of stress in the home when the inspectors are on site.
Okay, Mr. Chair, that was my final question, was about, this could very well be connected to stress, and you mentioned that. So I appreciate your comments. Thanks, Jennifer.
Thanks, Jennifer. And, it is odd that, with all the horror stories that have been provided in the media, with some long-term care centers, and then, the talk about the reduction in the number of inspections, it doesn't appear like that's happening here in Grey County. So thank you, Jennifer, for that update. Is there any other questions of the report? Christine, go ahead.
Thank you, Mr. Chair. So I appreciate the information provided by Jennifer staff with regard to the inspections. My question is, in developing the quality assurance plan for 2021, will these inspection reports also form part of that overall plan?
Yes, these inspection reports will form the overall plan, and they will also guide what education, the annual education that we do for all staff, what areas of concern could be put to surge training for annual inspection. Sometimes it's a very small part of a bigger regulation, and we will concentrate on the part that we see has come up over and over again through the critical incidents or the inspection reports. So yes, it will be.
Are there any other questions? All in favor of the report? That is carried. Good morning, Warden Hicks.
Good morning.
Nice of you to join us. Thank you. Okay, we now have LTCR-CM-02-21, the long-term care COVID update. Can I have a mover to get that on the floor, please? Moved by Dwight and seconded by Brian. Jennifer, are you starting this report?
I am, Mr. Chair.
The floor is yours.
Okay, thank you very much. So this is our COVID update, and I appreciate the flexibility of the committee in receiving this closer to the moment, because there's so many things that change day to day. So this report, and even there's been some updates since this. So I'm just going to focus today on testing, staffing, and vaccination. So testing has evolved from every 14-day mandatory surveillance testing of all staff and designated care partners to every 7 days, and that aligns with the provincial lockdown that goes until January 28th or perhaps longer. So now we have our staff and our designated care partners, which you'll see in ministry documents called essential caregivers, every 7 days. And all 3 homes are offering that testing on site. So I'm able to slip over to one of the homes. Yesterday I was at Grey Gables and I had my swab. So thanks to that team for, I don't know whether they draw the short straw having to swab the director or the long straw, I'm not sure, but it feels long when it goes to the back of your brain. So anyway, the testing is now every 7 days, and the family members, the essential caregivers, are very, very grateful of the opportunity to be able to go on site and have their test. They get to see people they know. They don't have to stand in line with potentially sick people. They don't have to figure out booking with an assessment center, et cetera. So I'm really appreciative of the teams and the homes in making that possible. The other update, I guess, with regards to testing is that sometime last week, the province updated the directive to include rapid antigen testing. And so all long-term care homes in the province now have the opportunity to move to rapid testing, which is it is still a nasopharyngeal swab at this time. We understand it has the capacity to be a deep nasal, so it's not as feeling invasive, but right now it doesn't say that in the directives. And if we were to switch to the rapid antigen testing, the required testing is 2 to 3 times a week versus every 7 days. You do get the results within 15 minutes, and the benefit of rapid testing is well, the purpose of rapid testing is to be used as surveillance testing where you expect most of the results or the majority of the results to be negative. That's how it's been described. And so because we're really wanting to put our focus on vaccination preparation and being ready for the moment vaccines arrive on the doorstep, we are going to not switch to the rapid testing for all surveillance testing immediately. We're gonna wait a little bit. Public Health, Grey Gables Public Health is shipping us 200 to 400 rapid tests to have on site, and through direction and partnership with Public Health, we'll be able to use those rapid tests when and if we get any potential false positives or indeterminate tests. We can then use a rapid test. We still are required to do the gold standard PCR test and send it away, but we can use the rapid test on any residents that were potentially at risk or any colleagues that were potentially at risk to help ease some of that stress and have a better picture of what the status is of a potential outbreak. And we would do that under the direction of Public Health. That's not something we do kind of on our own. So that's the plan right now for testing. We're going to get focused on vaccine prep and then transition to the rapid testing after we get that sorted out. It is a logistical thing. We need to sort out how do we test people from once every 7 days to 2 or 3 times a week. Do we have enough human power? What does that look like? So there's some logistics and details we need to really be prepared for to do it well. Visiting and designated care partner program. There were some shifts in the program that had to happen in alignment with the provincial lockdown. And so there are no general visitors allowed during the lockdown. There are designated care partners are able to come into the home still safely, 1 at a time. Prior to the lockdown, they could come in 2 at a time. That's the biggest significant change. We also have made some modifications to our window stations to protect visitors from the elements. So we still are doing window visits, and those are booked on the online booking tool. And the homes have created some unique spaces that have some shelter from the wind, and some have heat, a little bit of heat, and so that to try to get us through the winter. We sent out an experience survey to the designated care partners, to the staff, and to the residents, and we're still working on putting all of the responses together. But a highlight at the time of writing this report, we're very positive. So 100% of the residents are satisfied with the program. 94% of the DCPs answered somewhat to very satisfied, and 87% of the staff are satisfied with the program. And that's a real win. To me, it's evidence of this shift in the way healthcare, how we in healthcare as workers are shifting our way we think about family involvement, and that it's a very positive thing. And so I'm really, really pleased with that. This is interesting, on average in the last month, how often did the DCP come in? And so this was good because I didn't know what this would look like as the program rolled out. So 10% visited every day, 32% visited 3 times a week, and 45% visited once a week. So that's a nice balance, and it means we're not overwhelming the home with visitors, too many visitors. How confident do you feel that the infection control procedures in place are keeping you safe while you're visiting? And 98% felt they were somewhat confident to extremely confident. And do you feel confident that the community has an adequate supply of PPE for you as a DCP? And 96% answered yes. So really positive response from the designated care partners, the staff, and the residents. We are continuing to work with the Evaluation Collaborative Group, and we're part of a research program and part of a national long-term care plus program to spread best practices. And so we're working on that. Staffing, I mentioned in response to a question a little bit earlier, that we continue to recruit staff at all levels in the home. And this wasn't part of the operational report because I didn't have the information confirmed for the operational report, but I had it for this, that we have successfully recruited the clinical specialist position, and we're really pleased to welcome Dana Leach to the Grey County Long-Term Care team. She's going to be a real asset, and really, really excited to have her come aboard, and she will begin work on February 8th with the county. Brief update on funding. The HR and finance team and payroll team has worked really hard, lots of extra time in between their regular duties to sort out and get rolled out the additional PSW pandemic pay. And to be able to do that in alignment with the reporting timelines that the province determines, and lots of logistics and lots of nuances there. And so we're really grateful for all of their efforts to get that rolled out, and the PSWs will be seeing that payment in a couple of weeks. Vaccination.
Jennifer,
yeah.
The pandemic pay, is that in effect from October through until the end of March currently?
Yeah.
Okay, thank you.
And it's for PSWs only. Yeah. And then the highlight and light in the tunnel is vaccine, and that's ever evolving, and we're very grateful for Grey Bruce Health Services and all of our health partners in advocating for vaccine getting to Grey Bruce, and long-term care being on the top of the list. We're really invested in using good language around vaccine, and so I'm trying not to use the word priority. I think our goal should be anyone that wants a vaccine should get a vaccine as it becomes available. And so it's a phased-in approach. And so we know there are 1,000 doses of Pfizer coming the week of the 25th, and we're ready. And I'm telling anyone that'll listen, if Pfizer or Moderna shows up on our doorstep, we'll be ready to go. And so the teams are gathering consents and making lists and sending that to public health. And yeah, so I know the public health has been working really hard to advocate and get vaccine to this area. So we're really grateful for that. And yeah, so we're working away on that. Lots of partnerships happening, continuing to happen, and we're really grateful for that support and happy to answer any questions.
Okay, thank you, Jennifer, for that update. Any questions from the members? Warden Hicks, go ahead.
Thank you, Mr. Chairman. Jennifer, on the vaccination piece, I hear a little bit about things that we are doing to prepare. Are we confident that we're going to be in a position that a mobile truck rolls up to one of our long-term care facilities, and in that day, we will have all the paperwork, all the sort of red tape, all the things that need to be done for people to be, vaccinated, an injection in their arm that day?
Yes, I see nodding. Shannon's nodding, Stacey's nodding, Karen's nodding. Public Health has started holding meetings with us last week, and even probably before last week. And the province has been circulating consent forms and checklists so that we know what we need to do to get ready. And so we have it's a consent form that is a standard consent form developed by the province. And so we can get that signed. We are doing the education for both the Moderna and the Pfizer. We've been doing lots of reading and sharing of information to support any of the folks that are a little bit hesitant, so that we can make sure they have all of the information to be able to make a good decision about whether they get the vaccine. But yes, our goal is that if we got a knock on the door this morning, we could start putting vaccine in people's arms this afternoon.
Right, and can you tell me a little bit about what the thought is around the actual process? So are people going to be going from room to room to deliver the vaccination? Is there going to be a central place that the residents will be brought to have the vaccination given? How exactly are you thinking that will work?
Sure. Thank you for that question. It's the homes, and so I can give you a high level answer because I'm not a nurse and I haven't been doing this, but our homes are very skilled and experienced in doing influenza vaccines for decades. And so we'll take a very similar approach to doing our COVID vaccine with our residents as we do with flu vaccine. And that's a cart that goes to the residents, a nurse and a cart, and they go to the residents. We have the consent forms already gathered ahead of time, and they have a list, and they go person to person and administer the vaccine. For staff, we do clinics where usually we do a hybrid. So often there are clinics where the staff go to the nurse, and so it's a central space in the long-term care home. And then sometimes the nurse goes on the road, so to speak, through the halls and catches people to say, hey, do you want a vaccine? Come and see me, and catch people that way. And so that's our plan. It would be on site, and we would roll it out the way we do. We'd fashion it after our influenza clinics.
Mr. Chairman, if I might.
Yes, go ahead, Warden.
Jennifer, there's been a fair bit of discussion about the vaccination rate. So how many vaccinations can you dispense in an hour? And are we convinced that we are doing everything to speed up that process? In other words, can some of the prep work be done by non-nursing staff, and can some of the watch afterwards be done by non-nursing staff, so that the nursing staff is freed up to actually inject the vaccination?
Yeah, through you, Mr. Chair. Thank you. And I'll maybe look to Renata as a clinician with maybe some experience around the flu clinic. I don't believe the nurse stays and monitors the resident for the 15 minutes, but the PSWs provide support in that.
The PSWs provide support. There is an extra nurse generally that day, or a nurse or two, that is booked to give the vaccine, along with the regular staff that are booked for the day on the floor. So there are people available to monitor the residents. And that would be the same at a clinic. There would probably be one or two nurses, and there would be an area set aside where staff can sit and wait the 15 to 20 minutes before they leave to make sure that they're not having a reaction. So that would require a nurse to be there. But the paperwork and the prep work to get things ready can definitely be done by support staff, the forms, the filling out of the forms, etc. But the watching and making sure that there are no adverse reactions would be from the clinical staff.
And Warden Hicks, we've already started doing that paperwork. And so with our surveillance testing, the COVID swabbing, we have a unique opportunity that we haven't had historically for flu vaccine. And that's an opportunity where a clinician, a nurse, an RN or an RPN is face-to-face with a staff member doing the swab. And so we're also using that opportunity to talk about COVID vaccine, to hand out the paperwork, to gather their information. And so that paperwork has, the public health sent us the spreadsheet midweek last week, and we've been gathering the information into the spreadsheet, you know, the details, their name, their identification number, address, etc., and then getting their consent signed.
Yeah, thank you. Sorry for digging so deep into the weeds, but it is of interest, I think, because people are wanting to see that these vaccines get out as efficiently as possible.
Absolutely.
Sometimes we need to get into the weeds, Mr. Ward. We'll go to Brian and then Christine.
Thank you, Mr. Chair. Jennifer, the overall list, the priority list, do you have that already? Like when they're doing Lee Manor, when they're doing Grey Gables and so on? Like you're not going to be surprised that bang, this coming Friday, you're going to be doing vaccines. And are you going to get, how many of our homes will get done within the first wave?
Jennifer?
Yeah, thank you, Mr. Chair. Sorry, if I move my mouse, my internet does this wobbly thing. So can you just repeat your first question, Councillor O'Leary?
I'm just wondering about the big list that you get from public health. Is who's going first and will you be able to do complete home pay or all that?
So thank you, through you, Mr. Chair. So some of those details are still needing to be ironed out, and public health has established or is in the process of establishing a task force to help determine that. And so the challenge right now is available vaccine. So what we know for the end of January is that each long-term care home in Grey Bruce is to provide a list of 15 to 20% names of their staff who would go to public health unit to have their vaccine shot when it arrives. So that's how that first 1,000 doses. So we are really only going to be having, 8 to 15 people per staff per home in the first phase, that week of last week of January. After that, now there's more evidence and more opportunity to have the vaccine delivered to the long-term care homes. And my understanding is the next batch of vaccine is going to be delivered to a long-term care home and not be divided up amongst the 19 plus the retirement homes plus other congregate settings, and they'll do one home at a time. In Grey County, in our 3 Grey County homes, we have the benefit of an environment that allows us to more easily isolate and cohort our residents and our staff. So I think that the vaccine, when it comes in small batches, is going to go to the long-term care homes first, who have older buildings, 3 and 4 bed wards, and are environmentally have challenges in isolating and cohorting their residents, and that will be the homes that are vaccinated first. So I don't think our 3 homes will be first on the list for the small batches as they come in, but we are in that first list of long-term care before it goes out to other sectors.
Thanks, Jennifer. That's all, Mr. Chair.
Okay, thank you. Christine.
Thank you, Mr. Chair. 2 just logistics inquiries, if I might. Jennifer, I wonder if you could just speak to the follow-up 21-day vaccine and the plan and the rollout for that. And secondly, if there is an individual at one of our long-term care homes that is not able to receive the vaccine during the schedule, what would be the follow-up for that particular resident? Thank you.
Okay, for the resident, sorry, or the staff member?
Actually, the question could be for either staff or resident. Thank you for the clarity.
Okay. So thank you for those questions. I'll start with the last question because I remember it. So if someone doesn't get their vaccine because they miss it that day, if we have enough vaccine and are able to store it, we will make it available. We will do vaccines in the way that we're doing our testing. We're going to take a similar approach. So we are trying to make it as easy as possible for staff to have their COVID test on site and have it within their time frame. So we'll take a similar approach. We're going to be as flexible as possible. All the registered staff can give vaccine. So we will have some dedicated staff that come in and do the clinics, but all registered staff can do the vaccine. So as I said, our goal is that as long as we have it available and it meets the criteria outlined by public health, anyone who wants it will get it. Can you just remind me your first question? Sorry.
Certainly. My first question was just around the 21-day.
Oh, right.
So thank you.
Okay, thank you. Yeah, so we'll, again, some of these details are going to be provided to us from public health on what that looks like, because I've been seeing across the province different approaches, and I'm not sure exactly where everyone's landed with holding doses back or not. But we would have our goal would be to have a system in place at the beginning so that people know to come back in the 21 days or the 28 days. And something to be noted, it's anecdotal evidence, but I've been following along on other parts of the region of the province that have been getting their second doses and some people in the United States. And they're finding this day after their second dose, they're having some more effects than they did their first one. So we're taking that into consideration as well. And we're not going to have, say, all of our RNs have their first shot at once, and then all have their second shot and maybe not be able to work the next day. So we're dividing up our list as well across the different classifications and the different workers.
Thank you very much.
Dwight, did I see your hand?
Yes, you did. Thank you, Mr. Chair. Jennifer, just a different kind of question. What protocols put in place for the people, since it's not a mandatory vaccine, what protocol have you put in place for the people that do not, staff and patient? And
well, and that's a really good question that we don't have a firm answer on. So there hasn't been a final direction made by the province on that. And so right now we're waiting for that. Influenza vaccine is similar. There is no, it's not mandatory. So we do a lot of work in making sure people have evidence and an opportunity to ask questions and understand, so they're making an evidence-based decision. And so we'll do that, and we are doing that with the COVID vaccine. So they may need to be, what I've heard is they may need to still wear PPE, and what level of PPE I'm not clear on. So we're watching for that to find out what the direction is going to be.
Go ahead, Dwight.
Oh,
you're on mute.
Just to follow up, Jennifer, for with the mass of the home, including staff, get the vaccine, does that not help in one sense with the people that do not get it?
Yes, I believe so. My non-clinically trained answer is yes. And we're hosting a virtual family meeting next Tuesday, and 2 pharmacists from our pharmacy that we work with are coming to help answer questions. And so I might be able to speak better about it after that. But yes, and I think there's a whole class of education that we could do on herd immunity and how that works. But the higher the uptake of the vaccine, the better it is.
Renata, I think I saw a smile from you. Did you want to comment on Councillor
No,
Burley question?
Sorry, yes, I was just smiling at Jennifer is doing really well for being non-clinical. And yes, I believe some herd immunity would be helpful. The higher the uptake, the better the protection. And for those people who are not going to take the vaccine, they would still be wearing their PPEs. And that's the direction that we've heard so far. Sorry.
Can I add?
So just to be clear, Renata, like if you get the vaccine, then you won't have to wear all the PPE. So there's a real advantage, or no?
No,
you'd still have to
not
wear
right
it?
now. Right
Okay.
now, all precautions would stay in place.
Okay, thank you.
Can
Are there
I
any
just
other
add?
questions? Barb, go ahead.
Thank you, Mr. Chair. And I can be heard. I can't mute my device.
We're not able to hear you, Barb.
And I can't mute it, and I'm getting that stop signal that the Wi-Fi is really fluctuating. So I'll excuse it. No problem.
We can hear you now.
Technology, isn't it fun? Thanks so much for this very, very in-depth reporting, Jennifer. You've done extremely well, and all of your staff. Choose notes as I was listening carefully. One about the priority and the language you use. I think it is very, very comforting to all of us to know that our most vulnerable are considered a priority, and I don't think anybody should apologize for that. That's perfectly fine language in my book. Second, my question is with regard to the length of time the vaccines can be kept out of the deep freeze when they're delivered. Is there a shelf life, and is there a time factor in terms of the use and the distribution of those vaccines once you receive them?
Thank you, Mayor Klumpus. So I'm not going to, I know that there is, but I'm not trained enough to be able to speak to the specifics of the shelf life. And this is where our partnership with public health is so important, and we value their expertise. And I'm confident that as we get closer to the moment, that information is going to come, and they have a team that's going to be available to support us with any of those questions and the logistics and the details like that. But I do understand that that does matter, and we need to be prepared for that.
If I may, Mr. Chair.
Go ahead.
And that was where I was headed with that question, was in the relationship with Dr. Era's proposal for distribution in smaller locations, rural locations, and how will our long-term care facilities comply with or be included in his proposal and his model that he's proposing.
And I think that since that proposal, there's been new information and successful delivery of Pfizer to long-term care homes in other regions. And that's a game changer, and is going to make it so much easier for our residents to be vaccinated in a timely way. And Dr. Era and his team has talked about that in the recent days. And so that's really, really good.
Thank you.
Any other questions?
If I can
Jennifer,
just add.
I do have one question, Jennifer. You mentioned cohorting. Can you just, and the the environmental advantages that some of our county homes have, can you just maybe highlight for the committee members what cohorting looks like in our facilities? And I'll leave it at that. Thanks.
Sure. Thank you, Mr. Chair. So it is a little bit different in each of our 3 homes, but basically it's the ability to isolate a resident by themselves in a space where they follow all of the precautions. They're not they're further, they're not too close to other residents. So if any of our residents have symptoms of any kind, our first step is to isolate, test, contact public health. We kind of do that all simultaneously. And we have the ability in slightly different ways in all three of our homes. Some are extra rooms that have been made into isolation spaces. In other homes, like Rockwood, has converted a lounge or a living space into an isolation space. So we have the physical layout to be able to do that, where some of the smaller, older facilities don't have that ability.
Okay, thank you. Sorry, any other?
I
Yes,
do
go
think
ahead.
CAO Wingrove.
Kim, go ahead.
Thanks so much, Mr. Chair. Just a couple of things back to some earlier questions. You'll have seen from the media that that UHN in Toronto has been undertaking some pretty significant vaccination of their staff, and so they have posted frequently asked questions as guidance to them, which I anticipate will be a standard across the whole sector. As far as people not getting vaccinated, they're very clear that there are people that have allergies to some of the substance that's used to make the vaccine. There are also people with pre-existing conditions that wouldn't get vaccinated. So there is some guidance there. The other thing about if I get vaccinated, can I stop with COVID-19 and public health measures? And this is maybe something that hasn't been talked about quite enough. They're saying although vaccine provides protection to you against symptomatic COVID-19 infection, we're not sure at this point if it prevents the individual from spreading the virus to other people. We must remain extra vigilant as infection rates are at record highs and wide vaccine rollout will take up to a year. Everyone, vaccinated or not, must continue to mask, practice physical distancing, and maintain hand hygiene. So.
Thank you, Kim. And sorry, I just see your little hand up in the corner of your screen.
That's
now.
okay.
I wasn't looking for that.
Not to worry.
Are there any other questions? Okay, all in favor of the COVID update report? That is carried. Okay, we have LTC-CM03-21, the 2020 write-off of uncollectible accounts. And Joanna, I believe that you're taking us through this report. The floor is yours.
Yes, I am. Thank you very much, Mr. Chair.
Sorry, Mr. Chair. Sorry, Joanna, just before you continue, can you get a mover and a seconder for the motion, please?
Sorry, I'm new at this. Can I have a mover to get this on the floor, please? Moved by Brian and seconded by Barb. Thank you.
Okay, thank you, Mr. Chair. So the purpose of this report is just to advise the committee on the long-term care write-off amounts for 2020. So in total, we had approximately $8,629 in bad debts, and that's split up about $4,503 at Grey Gables and $4,126 at Rockwood. And both those amounts are actually a very small amount when you compare it against the actual resident co-payment. So it's we actually collect about 99.7% of our co-payment amounts. We do have a direct debit payment plan where people it automatically comes out of their bank account. There are some people that pay by check, and unfortunately, there are some people, that just haven't paid. Now, the ministry does cover 50% of these arrears that relate to basic accommodation, as long as the write-off is made in the year that the arrears relate to. So we would get $4,300 back from the ministry. And while we write off these amounts for accounting purposes,
Has everybody else lost Joanna?
Yeah, Joanna froze.
Yeah,
okay.
Yeah, that's the report. Happy to answer.
Sorry,
any
Joanna,
questions.
can I just get you to go back about 30 seconds into your address because you froze on us?
Oh, I'm sorry.
Right after you said what the province provides.
Okay, so the province provides 50% of the arrears back to us, and that's only if we show them what efforts we've made to collect. So although we do write off this amount for accounting purposes, we only do it for the purpose of receiving our reimbursement, and we do continue to try to make collection efforts.
Okay, thank you. Are there any questions of Joanna's report? Go ahead, Warden.
Thank you, Mr. Chairman. Joanna, at the time of the write-off, is the account then frozen, or is there the possibility of further arrears?
Joanna?
Thank you. Through you, Mr. Chair. I guess there is the possibility of further arrears because some of these residents may actually still be in our homes and still residing as our residents. I don't know if one of the executive directors want to comment on that.
Who would like to comment on that? How long do arrears continue to amass?
I can comment on that, Mr.
Okay,
Chair. It's
Jennifer.
Karen. It's Karen, actually.
Oh, Karen, sorry, go ahead.
So certainly if the resident still resides in the home, there's a chance that their arrears may continue. We do have some options to take in meeting with the resident and or power of attorney, and we often involve the social worker in that process. If the resident is not already residing in a basic room, we would take steps to move them to a basic room. We would make sure they've applied for all the financial benefits they can receive when doing that. And we would also stop any non-funded services like hairdressing, cable TV, kind of those extras. So there are some steps we can take to mitigate it. But at the end of the day, they would still be a resident within our home, and there is the chance that the arrears could continue to grow.
Okay. Any other questions? Okay, all in favor of this report? That is carried. Thank you. We now have CAO R-CM-03-21 Behavioral Supports Transitional Unit Proposal Update. And we'll turn the floor, oh, sorry, can I have a mover to get this on the floor, please? Moved by Christine and seconded by Dwight. Kim, we'll turn it over to you. Thank you.
Thanks, Mr. Chair. So I'll start off, and then it may be that Shannon and Jen will fill in some additional details after I'm finished. So the purpose of this report is to update the committee on the status of our application to implement a behavioral support transition unit at Grey Gables, and to seek approval to undertake further negotiations with the Southwest LHIN and the province regarding the terms of an agreement. As outlined in the report, the county was approached by the Southwest LHIN several years ago about hosting a BSTU. Staff worked with the LHIN and the province on an operating and financing model, but ultimately couldn't come to an agreement that would work for everyone. So after the Lee Manor project lapsed, we were approached again, and the discussion shifted to locating the BSTU at Grey Gables. It was felt that the smaller resident home areas there could be a better fit for the residents and ultimately provide a dedicated BSTU space rather than an integrated one that had both BSTU and regular residents, and be more financially viable for ourselves and for our funders. That proposal also included, the current proposal also included resources to document the operating and implementation plan to provide a proof of concept for other rural long-term cares to benefit from. I'm going to stop right there and just ask the committee members, does everyone know what a BSTU is? Or do I need to just review that for folks?
Warden Hicks, go ahead.
Thank you. I do know what it is, but I would appreciate a refresh, particularly around the word transition.
Okay. So I'll start, and then Renata, you jump in where I've missed the bus. As people go through the progression of a dementia or Alzheimer's type decline, there are stages in that, and for some people, depending on their particular characteristics and the nature of their specific disease, they may go through a period where their behavior is marked by an awful lot of what long-term care refers to as responsive behaviors. So that means in layman's terms that your environment has a lot of impact on how you respond. You might be more sensitive to noise or to light or to other activities or the presence of other people in your space. And then that can show up then as potentially even becoming violent, confusion, aggression, that sort of thing. Have I captured that appropriately, Renata?
Yes, yes, you have. And then the special unit where the staff are trained to manage responsive behaviors would work with the resident through interventions to have them, the transition part is that they would go to another long-term care home, or they would go to back home again. It essentially is convalescent care for responsive behaviors. If you look at it that way, it is for a period of time. And the idea is that they don't live there for a long period of time. There is no time limit on how long, but the idea is that they move on to another home. And the transition unit would then also for a period of time support them in the other home by conversation and the interventions that were in place, and hopefully the other home can continue with that. That way, there is always movement in the transition in the unit. So there's always opportunity for somebody else to take advantage. It is not a behavioral unit where the person lives there indefinitely. That is the biggest difference.
Okay, thanks.
So if I might,
Christine, did you have your hand up?
Yes, but it was covered off with Warden Hicks' inquiry. Thank you very much.
Okay, thanks. Gordon, go ahead.
Thank you, Mr. Chairman. I just want to make sure that I understand the transition piece, because if I'm hearing the explanation, it's that somebody would come to this unit with the idea that we're going to try to learn the specific needs of this resident, this patient. And once we know what those needs are for this individual, we'd be in a better position to understand where they need to transition to, whether it's back home or to a different, in other words, what facility and what circumstance would work best for this person once we have them in this unit and assess their needs.
Assess their needs and then provide interventions to not necessarily control, but to manage their needs. So what is it that is causing the behavior? Is it the lighting? Is it the noise? Is it the ability to wander around and have the space to do so? Is there special pieces of equipment that would help with the behavior when the behavior happens? And then create a plan of care for that, and hopefully move that on to the next home that they're going to.
And Renat, is it not true too, as people move through their own disease process, some of this may change or alleviate itself?
That's correct too.
But those folks are not, it's just best where it's possible to have them in a space where they can be cared for without impacting the others. So.
Others, that's correct as well. Yeah.
Renata, there was talk about some of the physical changes that we would need, to the facility, and one including a locked or a confined outdoor space. How do we, so someone that wanders all the time, how do you replicate that in a facility that doesn't have a lockdown space? Or Jennifer?
I think that the plan, the proposal that was put forward to the province in March did outline some changes to the home area at Grey Gables, in addition to staffing and other operational concerns that would be addressed. So
right,
they were
but
going to make.
I guess my question, Kim, is if a locked approach is required for someone that is, for example, continually wandering, how do we transition those people to a home that doesn't have the physical barriers?
Well, I think that as far as placement of folks, that's the placement coordination piece happens through the LIN. And so they would be the ones who were aware of the requirements of that individual, as Renata's speaking to the plan of care that would be developed for a resident.
All right, thank you.
Okay, so
okay, continue on, Kim.
Thank you. Okay, so we started talking about moving a BSTU to Grey Gables. With this committee's support, we submitted a project on March 10th to the province, and then COVID happened, and then we didn't hear anything more about this until last Tuesday, which is why this report was a late addition to the agenda. We received a letter indicating funding approval for the proposal, but that funding approval is backdated to November of 2020. And the project is set to be a pilot until March 31st of 2022. They've asked that we sign back by January 18th, next Monday, at which point we could begin accepting placements once a bed became available. So as staff, we have some concerns about the changes to our circumstances since we submitted this application and what's happening in our environment, and a lot about the short project window that's being provided. It is standard practice for a BSTU to be implemented on a pilot basis. I was told 2 years ago probably that that's just the way they do this. So I don't really read anything into that. But I think there's some other things that we want to consider and address. So overall, I'd ask the committee to support some principles as basis for some discussions with the LIN and the province. I think we all continue to support the need for a BSTU and would be willing to move forward with the project as long as certain criteria are met. And those criteria, staff resources. Right now, we cannot divert any of our current staff resources to support this. We can't begin as soon as we sign back because we'll need ramp up time to recruit new staff and to train everyone who would be a part of this. I don't believe there's a financial concern at this time, but another principle I think we want to be clear about is that Grey County will take this on as long as there's not a financial or a levy impact. This needs to be treated separately from our regular long-term care service provision. And we need to have a sufficient timeline to make this project successful and worthwhile to meet our objectives about developing and documenting this. So the province will need, I think, to agree to roll that current fiscal year funding that should expire by March 31st, that was in excess of $900,000, into next year, so after April 1st, and I'd like to see them extend the pilot to 2023, so that really do get an opportunity to work through this. The other piece that I want to have some discussion with the LIN about is a better understanding of how this project is intended to impact the wait list at Grey Gables. Are we saying that placements will be made into the BSTU only when there's a vacancy in that specific home area? Or are we expected to move residents around in the home to expedite freeing up spaces for those who require BSTU services? Under that circumstance, I think there could be some significant impact to people on the regular wait list. They would see their waiting time extended potentially significantly, simply because we don't get that much turnover in beds at Grey Gables. So I don't know if Jennifer or Shannon wanted to add anything further, but have I missed anything?
Okay, thank you, Kim. Jennifer, anything?
Well, that was an excellent summary. Thank you, Kim. I think the only thing I would just reiterate is that we believe in the validity and the need for the project. And because of that, we want it to be successful and we want our residents and our staff to be safe. The training is really, the time to prepare and do it properly is what will make it successful and safe and a viable project. So I just wanted to reiterate that.
Shannon, anything from you?
No, it was great. Thanks for doing that.
Okay, questions from the committee members. Christine, go ahead.
Thank you, Mr. Chair, and I certainly see the merit in staff undertaking further consultation and discussion with regard to this potential for our long-term care homes. Every month we receive an operations report which address the Ontario standards and where each of our long-term care homes fit within those standards. I'm wondering that through this this pilot project, should it move forward, would there also be operational reports that would be addressed on a monthly basis? Does that impact on the operations currently, or do you see that being reported seamlessly? Just some comments in that regard. Thank you.
Renata, do you want to take that? There's very extensive reporting, I think, that's required here. And we've proposed additional staff, dedicated staff,
Yes.
One of which is just about documenting it. So
yes,
that's correct. There are extensive indicators attached to the project, and they would be reported on. And yes, we have added extra staff to assist in the unit with all of the requirements for the data collection. So there is a coordinator attached to the unit. I have an 8-week-old puppy at my feet at the moment.
I knew somebody had it.
Yeah. Where it was coming from. I thought maybe Brian was doing something there.
It's an English Springer Spaniel, and his name is Joey.
Nice.
And he joined the meeting. I'm sorry.
Okay, other questions? Warden Hicks, go ahead.
So just a comment, Mr. Chairman. I have long been saying that if there's something that I can get excited about, it's this. You know, the experts have been telling us for the very longest time that we are going to be facing a tsunami of dementia in our healthcare system. I would love to see Grey County develop some expertise in caring for people with dementia. I'm really excited to see this kind of proposal come forward. I think there's great possibilities at Grey Gables. Sounds like there's a lot to be ironed out, including, of course, making sure that we can staff the darn thing, and you know, that we can do it in a way that's financially responsible as well. So I'm glad that, Kim, you're on top of those areas, of course. But the fact that we are even talking about this is, to me, very exciting.
Thank you, Warden. And I would certainly, you know, share that it's a program that I think is certainly required, you know, as a system. My belief is that it would be a regional unit that wouldn't just be Grey County residents. It would be the northern part of the Western region, and then certainly, you know, an opportunity to provide the quality of care that the people with these responsive behaviors deserve. Kim, you touched on the budget and no levy impact, and I think because it is a regional resource, there shouldn't be a budget impact. Can you just you know, maybe, you know, update the committee on, you know, where the numbers are right now, and are they sufficient that there wouldn't be a budget impact?
Yes. What the province is proposing to provide, and what we had indicated that we required, was noted on the last page of the report. So overall, the funding allocation that the province had noted they would make available to us is $2,248,838. We had indicated in our proposal a year ago that we would need one-time funding in the amount of $283,250. That was to make some adjustments and get the training up and going. And then year one expenses of 1.569. So by these numbers, we would be certainly have sufficient funds to go forward. In fact, some excess. I think maybe one of the points to make to the province is, though, in rural Ontario, given the, you know, the issues that we have around staff recruitment and everything, extra money doesn't necessarily take away the need for time, especially when we are so focused on ensuring that we're attending to all of the COVID matters. So while we appreciate them providing additional funds to us, it can't take the place of just the time that we need to appropriately plan and train.
Okay, thank you, Kim. Other questions from the committee members? So Kim and our senior management team is advising that the committee, you know, in principle, this is a good idea, but there's been some cautions provided to us around staff resources, around the no levy impact, around sufficient times for implementation, and how does it impact the wait list. So the resolution is that we support further discussion between the county and the ministry to develop a behavioral support unit. Is everyone in favor of that further discussion? We'll call the question. All in favor? That is carried. Thank you. Okay, Kim, it sounds like we get to proceed, but you know, please, the cautions that you provided us, please make sure the ministry is willing to play ball.
Thank you. I appreciate that. Okay. Yes, that's great.
Okay, we now have the redevelopment update. And Kim, that is likely you again.
It is indeed. Okay, so thank you, Mr. Chair. So I have lost my notes. Just 1 second. I'm so sorry. So I have two redevelopment updates. First of all, Rockwood Terrace. So as the committee is aware, the consulting team of SHS and Salter Pilon are hard at work on phase 1 of their project, which is the market assessment for housing on the site to go along with the new long-term care facility. We've had 3 project meetings, most recently on December 15th, and the next one's planned for next Tuesday, January 19th. The consultants from SHS were able to set up meetings with all of the different groups that had been identified as stakeholders to helping to inform that housing question. And they've held those meetings. They're just reviewing the meeting notes right now to tease out the key messages. And then they're going to be putting a summary together for us to consider next week. I expect that we'll see the draft market assessment at our meeting next week. Habitat for Humanity was someone who hadn't been on the list. They asked to contribute as they have some knowledge of housing need in the area, and so that's going to happen. Randy's connecting with the school board to discuss any future plans for the Spruce Ridge School and see if there are any opportunities or challenges that might impact a potential project on the new property. So we expect to wrap up phase 1 with that market assessment very shortly. And then phase 2 is the actual business case and business plan that will support that housing model that addresses the market needs and the county's requirements. Some of that specific planning work has begun. The rest will start shortly, and that phase 2 of the work is to be complete by the end of April of 2021. So that's the Rockwood Terrace piece. So what will come out of this is we will have a model and the numbers to support it, to look at what is the companion housing that should go on that site. And then once we know that, we'll be in a place to determine exactly how to site the long-term care facility, what site preparation needs to happen, et cetera. So then we'll be in a place to have a real project plan moving forward for the Rockwood redevelopment. With regard to Grey Gables, we put out an RFP just before Christmas for a consultant to consider what the highest and best use would be for the Grey Gables facility once the existing facility, once the new home is built. I thought it was important to understand how the existing facility could be repurposed, how it will connect to a new home, what things those two buildings might share. So the redevelopment options that this consultant will look at will need to take into account, we've got a very limited property there. So you wouldn't want to start into something that was going to involve needing a whole lot of parking because you're not going to have it there. The integration, mutual benefits. And so it's expected that the successful proponent will undertake an analysis that will underpin some recommendations that council will need to consider. We want to look at market demand, we want to look at revenue potential, we want to look at operating models and costs, and we want to understand what renovation costs might come out of that highest and best use. Right now, we're looking at a conversion of the current facility that would commence once the new long-term care facility can be occupied. So this is out in 2025. So that RFP process closes this Friday on January the 15th. We'll hopefully get at least a couple of good responses that we can consider. We know that we have the new long-term care redevelopment planning task force. That first meeting of that is January 22nd. So at that meeting, then I think that's where the transition, I think, will happen between redevelopment happening at this table and redevelopment decisions moving over to the new task force. I expect that that committee will take a look at the proposals that I got for the Grey Gables RFP, and I'll walk them through it, and then we'll make a decision on their comfort level in moving forward with an award. and the SHS Salter Pelon project for Rockwood Terrace will also, the new report that we're expecting next week from them will also go to that table and for consideration and adoption or further work being required. So that's where we are with the two redevelopment projects.
Thanks, Kim. Kim, you talked about some of the work coming to this long-term care committee of management, and then some work going to the new redevelopment committee. Can you just talk to us about what overlaps you see or foresee, and how do we make sure that each terms of reference are being met and that the appropriate information is going to where it should?
Right. Well, I think that, when we look at the terms of reference for this committee, your focus is on providing oversight to the operation of long-term care in the county. So where it comes to, I think, providing input into what we're proposing as far as reusing Grey Gables or some of the considerations for the new builds. I think some of those operational considerations, this committee absolutely needs to be aware of those and be able to provide comment on, if there's something that's being proposed for one of the new builds that would change something about the way that we're delivering that long-term care service. I think this committee, who would ultimately then have the oversight and responsibility for whatever it is we end up with, you folks should be aware of that and able to consider and have input into it. My feeling is that the redevelopment committee would use your comments from this table and the advice and guidance of the consultants that we're working with to put together that proposal, considering that all of this is pretty tightly scripted by the province, right? They will be going over everything that goes into our final proposal and our final construction drawings with a fine-toothed comb. So, while we do have some leeway, it's not carte blanche to build what you like, if I can say it like that. So does that help? I think
that
everybody
helps,
needs to be
Kim,
going together.
Yeah, no, that certainly helps, and hopefully there's some overlap between members on this committee and some of the same people being on the redevelopment committee. I think that would be a good tie-in, but that's just my thoughts. Are there questions of the redevelopment for Kim? Kim, from the chair, just one further question. The whole, with moving ahead with the redevelopment and the whole campus of care model that we've had presentations on. I think there's some members of our larger council that really don't have the same insight that this committee has with the campus of care. Is there any opportunity to maybe have the presentation that we were provided to the council, the entire council, so that some of those decisions moving forward would be better enabled if they had a better understanding of when we're talking campus of care, what that really means?
I was thinking that because SHS and Salter Pelon have been so involved in these projects in Simcoe, in Wellington, when it comes time for them to present the model, maybe that's the time that they can really provide all of that information and a good overview of the work that's been done in other jurisdictions, as well as what they're proposing here. Where is it the same? Where is it different? Why is it different? And really help the committee and all of council to understand that. Do you
No,
think that
thank
would
you.
that would work? Because they'll be the ones who really can answer all the questions about how these things have evolved.
No, I certainly think that would work. We've got a tremendous opportunity here, and I think we all want to get it right. So, thank you.
Okay.
Other questions around redevelopment? Go ahead, Barb.
Thank you, Mr. Chair. And to you, Kim, thanks so much for your report. I'm just curious about the province's expectations of the build for the expansion, I guess, of Grey Gables, the other project that we are looking forward to, in terms of creating immediately that campus of care model, as opposed to looking at a build specific to long-term care. Can you elaborate on that a little bit? Do we need to be worried about that? Because I think that's a very large ask for the deadline that they've provided.
Yes. Well, as I say, what we wanted to try and get a handle on is what's the potential of the existing building, because what went into the province in the proposal for the Grey Gables redevelopment did show the new building connected to the existing. So as long as we can have some clarity, given the information that is available to us right now, about what that connection looks like, so that we don't build something new and then think, well, we should have made it so that something else happened, some other part of the facility was better able to be shared, or we needed to use the space a little bit differently. But as long as we have that clarity around what we believe we'll be using the existing building for, we don't need and can't make changes to it for some time, because everybody needs to be into the new facility before anything can happen with the existing one. So, and they were very, like their definition of campus of care that they provided to us was very broad and was really about providing housing options or care options for the community. But they are not prescriptive about that part. And so I do think we have still quite a lot of leeway where that's concerned.
Any other questions? Warden, go ahead.
Thank you, Mr. Chairman. As we talk about this, it strikes me that there's, oh my gosh, there's so much to be done. I'm scared for staff, to be quite frank. So let's sort of look at the overview here of what we're talking about. We're talking about, number one, redevelopment. And under redevelopment, we've got Rockwood and we've got Grey Gables. That in and of itself is something I think that this team that we're going to be putting together can focus on. It's got a timeline to it, very specific parameters, very specific set of skills that need to be in play. That to me is just one of three. So I treat redevelopment as number one. Number two is this whole concept of campus of care. How does campus of care roll out? Is it appropriate for Grey Gables? Is it appropriate for Rockwood? Is it appropriate for Lee Manor? So I think that's an even bigger discussion, and perhaps a discussion for a whole other entity. Maybe, I don't know. Is it the same group that thinks about campus of care that is also thinking and planning around redevelopment? I think I'm concerned about that. And lastly, number three for me is the idea now of affordable housing, which seems to be coming into the mix. So we've got this land in Durham, and there are possibilities for other things there, and that fits into a mandate that we have around looking at affordable housing options. Is it the same group that's looking at redevelopment and the same group that's looking at campus of care that also looks at the affordable housing possibilities? My mind is just a little blown away at just how much there is there. And I know that that's why we pay people like him the big bucks, because they have to figure this all out.
And I do want to, I do want to assure the committee that, you know, we're just, what we want to achieve in the short term is just some sort of an overall vision, because in order to enable, in the Rockwood case, because that's the one that does have a hard timeline associated with it, we need to pull site services in there. We need to understand where the water and wastewater lines are going to run, what we want to do about roads within that piece, at least in the immediate vicinity of the long-term care home. What happens after that, we can take lots of time to think about that. But you know, it's just that, so you know, if we can get the first part sort of settled in our minds, so that servicing work can happen, then we'll be in a, you know, that will enable us then to work with the home redevelopment. But you're absolutely right. There are lots of things happening in.
Yes, and not to preempt what will a report that will be coming to council around the long-term care redevelopment task force. But my assumption is that the long-term care redevelopment task force will be preoccupied mainly with redevelopment, meaning the Rockwood and Grey Gables projects.
Yes, yes.
No, I think you're absolutely right, Warden. You know, we certainly have the redevelopment, and that is certainly, you know, at the forefront right now with the two long-term care redevelopments. But the campus of care is more of a vision and looking forward to what we may have an opportunity for on these sites. And certainly Grey Gables is far more limited than what the opportunities are at Rockwood, but you know, it's that vision of what we do moving forward I think is important. So thank you. Any other questions in regards to redevelopment? Okay, thank you very much, Kim.
Thank you.
Our next meeting date, I think, is scheduled in February. Does Heather, do you have that date?
We have a next date of February 26th.
Mr. Chair, on the agenda, it says February 16th.
Sorry, it is the 16th, not the 26th.
Okay, just wanted to confirm. Thank you. Is there anything else from any of the members before we ask for adjournment? Good morning, Kevin.
Morning, committee. You can just tell there's lots of work here.
Yeah, you may get more.
Yeah, I know. That's
okay. Can I have a mover to adjourn, please? Moved by Christine and seconded by John. All in favor? That is carried. Thank you very much for your patience with the new chair, and look forward to working with all of you over the next year.
You too. Thank you.
Thank you.
Bye-bye.
Thanks so much. Have a great day, everyone.
Thank you.